Good morning, everybody. As president of the Canadian Hemophilia Society, and on behalf of all people living with an inherited bleeding disorder, I welcome you to the first Canadian Conference on Bleeding Disorders in Women. In 1998, the CHS held its first workshop to bring together women affected by inherited bleeding disorders. From 2000 to 2003, the CHS conducted a major public campaign to raise awareness about von Willebrand's disease that culminated with the first Canadian Conference on VWD. Since that time, we have developed a variety of educational resources and offered programs to support women with bleeding disorders. More recently, the CHS Board of Directors identified improving access to care for women with bleeding disorders as a key strategic direction. During those years, Dr. Winikoff was instrumental in the establishment of the first multidisciplinary program for women with bleeding disorders at St. Justine Hospital in Montreal. In 2010, she proposed her vision that CHS bring together its many resources into a clearly branded Women and Bleeding Disorders program. As chair of the AHCDC Subcommittee on Women with Bleeding Disorders, Dr. Winikoff was the natural choice to chair the CHS advisory group. Out of this grew CODErouge, When Women Bleed Too Much, which we are launching today. We see this conference as a major initiative to educate and raise awareness. Thank you for your participation and enjoy the conference.
It's a true honor to stand up in front of all of you today, knowing that today will change history. I stand up here wearing several different hats, but none more important than the one I wear as just one individual, like most of you, who strive to make things better little by little for women suffering from bleeding symptoms due to bleeding disorders. As a group, we have succeeded today to take a huge step towards improving the lives of these women and girls. Through the commitment of all of you in this room, I'm confident that we'll continue to make significant changes. Today represents the consolidation of years of tireless work on the part of the Canadian Hemophilia Society, and in particular of the persistence and endless energy of the CHS staff and volunteers who over the years have laid the foundation of what is now CODErouge. No effort of this kind is possible without the dedication of the members, most notably the hematologist of the Women and Bleeding Disorders Subcommittee of the Association of Hemophilia Directors of Canada, or more commonly known by their very cool name, AHCDC, not to be mixed up with the rock group, of course, who never shy away from opportunities to educate, collaborate, and support endeavors for women and bleeding disorders. This subgroup is also the motor behind clinical and basic research on issues pertaining to women and bleeding disorders that has and will continue to advance care in this field. The high standard of care that is delivered to patients across Canada is thanks to the hemophilia directors and the healthcare providers at the hemophilia treatment centers. The nurses and other healthcare professionals of the hemophilia treatment centers are the patient's advocates, their liaison support system, and truly often run the show. They are a precious bridge to the patients, they are dependable support, and last but not least have the sometimes very daunting task of trying to keep us sane. Today we are privileged to have the SOGC as new partners in this remarkable journey. I am proud to mention that we have at least 18 obstetricians, gynecologists in the audience today, 5 family practitioners, and several anesthetists and researchers. Finally, I want to offer a heartfelt thanks to all of the members of the CODErouge Advisory Group for their help branding and developing CODErouge and organizing this very first national conference on women and bleeding disorders and help making this dream come true. Too many to name, but you know who you are. We as a community and as partners should be proud of what we have accomplished in the past, but also what we have accomplished today to change the future. It has happened because we share a common vision. This is just the beginning. Enjoy the ride.
The CHS would like to acknowledge the sponsors whose generous support has made this conference possible. Thank you to our presenting sponsor, CSL Behring, and to our participating sponsors, Bayer, Biogen, Octapharma, and Pfizer. I'd like to now invite Bonaventure, Agata of CSL Behring to give a few words of welcome. Bonaventure.
So first, let me thank you for the introduction. Let me start by congratulating Canadian Hemophilia Society and Dr. Winikoff for pulling off this first conference on bleeding for women disorders, for bleeding disorders in women. This, as I understand, is a culmination of years of hard work of many people from different groups: patients, healthcare professionals, caregivers, and of course, we in industry. Well, I have to mention that. Who have the passion of addressing the challenges that face hemophiliacs today. This is truly a remarkable achievement, and congratulations for all of you for the good work of advocating for patients. You couldn't ask for a better and more dynamic team. When preparing these remarks, as I always do, I was scouring through the internet just to get an understanding of the prevalence or incidence of occurrence of women disorders and the diagnosis rates. And quite frankly, the information was scanty for those of us who go to Wikipedia for everything, because the science sometimes can get very tricky. But clearly what's apparent is that underdiagnosis for women, for bleeding disorders in women, is a significant issue. Mainly because there's a thought that this is normal for women to bleed. This new normal, as you know very well, has an impact on quality of life, loss of dignity, just to mention a few of those side effects. And you heard the ladies on the front row discuss them in detail. Addressing these challenges faced by patients with serious and rare disorders is front and center of CSL Behring's mission of improving the quality of life of people with rare disorders, the so-called underserved diseases. The focus on the patient has to be built on a legacy of innovation, and hence this meeting that you have, which will expose you to new ideas and new ways to address this challenge. On a more personal level, I've grown up with women all my life. My mother is a woman. I grew up with 4 sisters. Can you imagine what type of a house? And today, I live with my wife and daughter. I've got a son, obviously, but in our family, I come from Africa, and people think that in Africa, the decisions are made by men. No. That's what you see externally. The decisions are made by women. And just thinking through all these people who have had an impact in my life have these issues. In fact, I recall, as we started having these discussions, 2 women in my bridal party, I won't name them, but they were pretty close. They were standing very close to my wife and I, had very heavy menstrual cycles. They had serious, I believe they were bleeding disorders. One of them eventually lost her uterus due to a hysterectomy. It's a big issue. In those parts of the world, the lack of understanding is a challenge. And I was surprised when I looked at the internet that Canada is no far from Kenya, where I come from. So again, what I want to do, and myself and my colleagues at CSL, is at least to be a small part in making a difference for women. And for that, we'll continue to support the CHS and the other professionals who are working in this area. Again, on behalf of my colleagues at CSL Behring Canada, thank you very much indeed for the opportunity of partnering to address one of the challenges we face today, bleeding disorders in women. Keep up the good work, and look forward to enjoying this exciting day. Thank you very much indeed.
Thank you, Bonaventure. The CHS is pleased that Mark Skinner, President of the World Federation of Hemophilia, has joined us today. I'd like to invite Mark up now to say a few words.
Good morning. Thanks, Craig. It's wonderful to see so many friends, and I don't know that I've seen you all in one room before. Canada's sort of like a second home for me, coming from the US and how much time I've spent up here over the last 10 years as WFH president. We really are one big global family. When Frank Schnabel, someone known to certainly all of you, had the vision to create the World Federation of Hemophilia, I have to believe in his mind that it wasn't just about men, but that he too shared the vision that we are a global family, and that the vision that we've embraced today of treatment for all meant more than just men with hemophilia. Since 2006, the World Federation has expanded upon Frank's original vision, and today we do have the vision of treatment for all. It doesn't mean just treatment with treatment products. It certainly means more than that. It means multidisciplinary care as well, but it also means taking care of all those with bleeding disorders, not just men, but women, those with inherited bleeding disorders, those with von Willebrand disease. Over the last 8 years, we've been working to expand the WFH global mission to raise awareness of the importance of issues related to women in particular and the rare bleeding disorders. And I do believe, and I'm really pleased to be here, that this is the first such conference dedicated to women at a national level anywhere in the world that I'm aware of or that others in the WFH are. So you are to be congratulated once again for being global leaders and helping us advance our mission. In fact, bleeding disorders don't discriminate. Beyond hemophilia, bleeding disorders are equally distributed between men and women. We only learned late in life. Of course, my mother is a carrier because I have severe hemophilia, but we only learned late in life that, in fact, she had mild hemophilia with a factor level in the low 30% range. And it was life-changing for her to actually understand why she was having problems that her sister wasn't having. So the scientific advances that have been going on, I think, are going to continue to change. We have very few women in total in the world diagnosed. Little over 60,000 women with bleeding disorders have been diagnosed in the world. In fact, we estimate that there should be about 6.9 million people with bleeding disorders in the world. The new data that we're going to be presenting at our World Congress is that 1 in 1,000 people in the world have a bleeding disorder. And hopefully this will help us raise awareness of the significant underdiagnosis and underrecognition of important conditions and the totality of our global family, including many of you in this room. So I just was really pleased to have the opportunity to be here with you today, to thank you for your leadership, to encourage you, and hopefully the spirit that you are bringing forward today will inspire others around the world to follow. Thank you.
Thank you, Mark. News about CODErouge has spread far and wide, and we've received some special greetings from international experts on bleeding disorders in women.
It's a real pleasure to be asked to make some introductory remarks for your conference of inherited bleeding disorders in women. In 2001, I talked at your Hemophilia Society meeting on this topic, and it's truly remarkable to see what's been achieved in Canada since this time. And this achievement is based on your tremendous spirit of collaboration and also your excellent scientific base. If we look at the history of bleeding disorders in women, we go back to the iconic paper published in 1926 by von Willebrand, when he described the little girl Hjordis, who died at the onset of her 4th menstrual period. Research in inherited bleeding disorders in women largely went into the background because of our search for very safe concentrates and the terrible saga of transfusion-transmitted disease. It wasn't really until the late 90s that we began to address attention in research to this area, and it was with great pleasure for us all that at last year's World Federation of Hemophilia meeting, one of the main speeches was given by Mark Skinner and had a large amount dedicated to this area. However, as you all know, a lot of challenges still remain. Perhaps the main challenge is educating the world outside haemophilia. There are many young girls who grow up in their teenage years developing anemia because people do not know they've got an inherited bleeding disorder. We also need to address ways in which we can get to communities that practice first cousin marriage and educate people about recessive bleeding disorders. Fortunately, genetic diagnosis has given us the tools to make carrier detection possible. But now we need to deliver this to those women who can then make better choices about their reproductive care.
Bonjour. Good morning. I'm Andra James. I'm an obstetrician gynecologist at Duke University Medical Center, where I'm director of the Women's Hemostasis and Thrombosis Clinic. I'm an educator, a clinician, and a researcher with a special interest in women with bleeding disorders. Welcome to the first Canadian Conference on Bleeding Disorders in Women. I am greeting you not only on behalf of myself, but on behalf of our center and the Foundation for Women and Girls with Blood Disorders. I commend the Canadian Hemophilia Society, CODErouge, and the sponsors for convening this meeting where providers can learn more about the unique needs of women and girls with bleeding disorders. Providers who care for women with reproductive issues may not be aware of the unique needs that women with bleeding disorders experience, and hematologists may not be aware of the reproductive issues that women with bleeding disorders suffer. So, welcome, enjoy the meeting, come, learn, be informed, and then go about disseminating what you've learned and implementing it in your community. Thank you. Welcome.
Yeah? Okay. I'd like to now introduce Pam Welton, CHS past president, who will be our MC for the day. Pam?
Good morning, everyone. It's really wonderful to be together with my CHS community and my family here. So really, we probably don't even need an MC because the day is so packed. So they're calling me MC, but what they're really saying is I've been tasked with keeping everyone on time. So I'm not usually a nasty person, but today you will see that side of me come out. Certainly, this is a historical day, and you've heard several people mention that to you. And I can't even tell you how excited I am. I'm nervous too. I'm nervous up here, but how excited I am to be with you because we've been working on this for a very, very long time. And in the beginning, the mums and the sisters and the wives who came together to help their sons, their husbands, their fathers who had bleeding disorders, maybe only whispered about some of their own problems, maybe in the washroom, maybe at the end of the day, maybe as we walked back to the hotel after a nice dinner together, we only whispered it. 14 years ago, we decided to do something about it, and we got together in Toronto during the historic Montreal ice storm. Patricia reminds me it was 14 years ago. We started to organize, and now here we are. And we are making history here today. This is the first, and it is, you're right, Mark, this is the first Canadian Conference on Bleeding Disorders in Women. It's the first in the world that we're aware of. You're sharing this moment with all of us together. Notice that the people who spoke about the first Canadian Conference on Bleeding Disorders in Women stumbled a little bit. Hardly anybody just let it flow off their tongue. But I bet in a few years, we're just going to be talking about this so easily because everyone will be taking care of it. So I do have some housekeeping. Claire mentioned at least 3 times when she was giving me the instructions that I may want to point out to you that in your bags you have this little blood droplet. It'll be lovely on your desk just to remind you of CODErouge, but really it's a stress ball. So if any speakers like me are feeling any nervousness, any anxiety, this will work. Personally, about 2.5 ounces of cheap red wine works better for me, but in case you're judgmental, don't judge me, okay? I'm using this. But in fact, I tried. You cannot get 2.5 ounces of cheap red wine in this hotel. So if you see me squeezing this, you know why. Also, because of the history we're making here today, and because we have almost 300 people with us, but we have so many other people we want to reach, we are filming today. So this will be on our webcast on the CHS website. So moving along, because I talk so much, I'll probably be the one keeping us late, Claire. It's my pleasure to again, and you've already heard a lot about her, so I'll just give you a little review. Dr. Rochelle Winikoff is the medical director of the Women's Bleeding Disorders Program of St. Justine Hospital in Montreal. She is an assistant professor of hematology at the University of Montreal. She has a clinical and research focus on bleeding disorders in women, and particularly on von Willebrand's disease. Dr. Winikoff is the current chair of the Association of Hemophilia Clinic Directors Canada Subcommittee on Women with Bleeding Disorders. Rochelle?
So thank you for that very kind introduction. I have a very difficult task before me today. It's a very mixed audience. I have to keep you entertained and also set the stage for the rest of the day. So here it goes. The real people behind the curtains that have been hiding for years are you, the patients. We have our ambassadors here representing across Canada patients, women with bleeding disorders. And that's what today's all about. It's very encouraging to know that times are changing. First in perceptions. So like we just heard from Pam, before women didn't talk about bleeding, menstrual bleeding, postpartum bleeding, it wasn't talked about. In some cultures, it's still not talked about. But now, women are painting with their menstrual blood. This is from a website of women who had periods who are very proud that they have menstrual periods, and these are actually paintings with menstrual blood. Industry has changed as well. And I don't know, I guess I'm too young to appreciate the real implication of this picture, but these are women washing out sanitary cloths after periods. And then the even more attractive Who's Your sanitary belt. I don't want to single out people in the audience. Has anyone here seen a Who's Your belt? No. Anyways, this was meant to keep the pad in place so that it wouldn't move around. Now what we have are disposable pads and tampons, as you all know. But a little bit we're going and turning around because now we actually have products that can be washed again, but this time not in the laundry, but in the sink. These are Diva cups. For most of you that don't know what it is, this is a cup that's inserted into the vagina to catch menstrual blood flow. It's cleaned and then reinserted and reused. It's not very popular in Quebec, but in other parts of Canada it's becoming so. Treatment approach has changed as well, and this is going to be a little bit of a quiz for you. So please note the picture. This is what it looks like now. Does anyone want to dare to say what looks different? Well, somebody said it over there. So the patient's now at the center of the picture. So I think that this is what represents maybe 10 years ago of what medicine in general looked like, but certainly women in bleeding disorders, where it was a very medical and paramedical discipline. Now it's all about the patient and the baby with all the support team around. Certainly collaboration has changed. It's not to say there wasn't any before, but today we have now merged together all these groups in what today is CODErouge. Current trends in women. First, I'm going to address the issues about menstruation. This is very interesting that pre-agricultural women had 160 lifetime menstrual cycles. Contemporary women will have 450 lifetime menstrual cycles. So we'll be faced with increasing problems, especially in women with bleeding disorders when it comes to the menstrual period. Why is it? Because of earlier menarche, low parity, no extended periods of breastfeeding, and late menopause. And just the opposite before, late menarche, high parity, extended periods of breastfeeding, and early menopause. But it's not just true for menstrual periods, it's also true of pregnancy. Women are having children at older ages, women are opting for assisted pregnancies. There's increased number of higher risk pregnancies, and therefore increase in bleeding risk and maternal morbidity and mortality. This is data from the Public Health Agency of Canada website, and I just want to point out that there is a slight increase in maternal mortality in adolescents, even though it doesn't reach statistical significance. The upper confidence interval here is 12. But where it becomes very a clear risk is as you pass 35 years where the risk of maternal mortality increases. So this is another issue we're going to be faced with in coming years. Looking at some of the perspective, it's true that inherited bleeding disorders represent only a small part of all women that bleed. But what is true is that the women that bleed represent a very significant number of women presenting to hemophilia treatment centers. Now, this is a slide that comes from the USA, looking at females treated for bleeding disorders at a hemophilia treatment center from 1991 to 2007, and it's very clear that their numbers are on the rise. That is true and representative of Canada as well. The health burden. So there's assessment of the prevalence and impact of anemia on hospitalized women. So anemia is actually a big burden. In a big surveillance study in the US, over 300,000 women were assessed that were hospitalized with a diagnosis of heavy menstrual bleeding and had a diagnosis of anemia. And those women with anemia were more likely to have been transfused, to have been hospitalized to the emergency room, and had higher hospitalization costs. The same is true for obstetric bleeding, where of the women that are hospitalized that have a diagnosis of anemia, there's a 9-fold increase in blood transfusion, longer hospital stay, and higher cost per hospitalization. For those of you that haven't seen this data, this is an interesting study that comes from the United States as well, where they looked at work loss estimated for women missing work due to absenteeism due to menstrual loss. And it estimates about $1,692 per year per woman. I just want to point out, though, that even though I showed 3 slides from the US, this was done by a Canadian economist. Quality of life issues, excess bleeding related to having a bleeding disorder has definitely a negative impact on a variety of things. And I need not tell the ambassador sitting in the front row, health and daily activities, social and sexual life. A lot of the time we don't talk about it. Enjoyment of life, mood, and sleep. And in a recent study, it was very clear that women scored that should read lower on quality of life questionnaires than women without bleeding disorders. Other quality of life issues that we don't talk about but have been published, up to 28% of women that have heavy menstrual bleeders will have generalized anxiety disorder and will have ovulatory pain known as Mittelschmerz. These are significant diagnoses that impair quality of life of women affected and could have also long-term sequelae. So what are the major hurdles that we're faced with in the upcoming years? First of all, I think the public. So I'm going to take you through this. This is in French, but this is a cutout from an article that we found in the Metro system in a publication called The Metro. This is a free journal that's given out. And this was pointed out to me by one of my colleagues at St. Justine in 2003. This was published on about a survey that was undertaken across the country in 2002, asking people on the street, do you know what von Willebrand is? And only 7% of the people were able to have a clue what it was, whereas almost 90% knew what hemophilia was. The other thing is when they said, well, if you don't know what von Willebrand is, can you try to guess what it might be? And the answers we got are quite, they're actually quite interesting. This says a German car. This one says Austrian armoires. And the last one says a mathematics school were the 3 popular choices. So we have a lot to do. Patients, there's roadblocks there. There are cultural differences. Patients might not complain, depending on their cultural origin. They may or may not. Hereditary bleeding tendencies run in families, and so we often hear the story, oh, my mom bleeds like that, it must be normal. And so there's a lot to do there. There's also roadblocks with the physicians or the doctors. So I'll read 2 quotes from papers that were published in well-known journals. Substantial differences in management exist between practices when investigating and prescribing for menorrhagia in primary care. And I'm not trying to target the family practitioners in the audience, but I underlined it. Rates of prescribing of effective medical treatment remain low. The decision to refer women impacts markedly on her chances of subsequently being operated on. Obstetrician gynecologists rarely consider a bleeding disorder to be a contributing factor in reproductive tract bleeding. I haven't found anything on hematologists, so I guess we're perfect. Inherited bleeding disorders. What are we talking about? This is just a synopsis slide, and I'm not going to take you through details, agonizing details of each one. I just want to mention them. Von Willebrand disease, hemophilia A or B, specifically symptomatic carriers of those diseases, rare bleeding disorders, combined factor deficiencies, and platelet function disorders. So the question is, as physicians, as caretakers, caregivers, I should say, in the world, nurses, physicians, and other healthcare professionals, it's very easy in some ways to look at an overt disease and say there's something wrong. And so I draw your attention to the acute hemarthrosis and the hemophiliac to the left. And then the question is the adolescent girl or the woman that comes to your office and is crying and says, I'm not feeling well, I can't concentrate in school, and I'm bleeding a lot. What do they have to show for it? And so this is one of the things that CODErouge and all these endeavors will help solve, is that they are bleeding, you just don't see it. And so this is definitely something we're going to strive to achieve, awareness. Von Willebrand's disease, the symptoms may be mild and nonspecific, and is therefore commonly underdiagnosed. And some data from the CDC shows an average of 16 years for an accurate diagnosis. So hopefully that data will change with time. Symptoms are often attributed to other causes or go unexplained. And then the big question is the prevalence of the disease versus symptomatic prevalence. And our colleagues in Kingston have done definitely a lot of work looking at that particular question, but I don't know that we know the answer in all populations yet. So many of you will recognize Erich von Willebrand that described von Willebrand disease in 1926. And the pedigree you see at the bottom is the family with von Willebrand, which we now know was most likely von Willebrand type 3. And the patient that was referred to by Dr. Christine Lee, Professor Christine Lee at the beginning is Horridus, who died of a menstrual period at 13 years old. Dr. von Willebrand described a family based on phenotype and based on bleeding symptoms. That was another generation, and now we go to a new generation where we now have Dr. David Lillicrap, who decides to describe von Willebrand disease in a whole different way, and now focuses the next coming decades on assessment of mutations in von Willebrand's disease. And then the next generation after that is Dr. Paula James, who says maybe Dr. von Willebrand was right. Maybe we should be describing the bleeding symptoms a little bit more. So we've come in some ways full circle. So what have I learned from this little part is that, so von Willebrand is probably ageless and also a woman. Hemophilia, this is a picture. Does anyone know who's on the left? Prince Leopold. Does anyone recognize him? This is who? Queen Victoria. So if you go on Google and you go on Wikipedia, what you're going to see is slide after slide of how catastrophic passing on hemophilia to the men in the family of Queen Victoria is. And so I put him in large, and a caption I took right from Google, Queen Victoria's male descendants were cursed with poor health. Poor Queen Victoria, no one paid any attention at all. So now I've put her in big, and we know that approximately 20% of carriers are symptomatic, and maybe we should be paying more attention to them. Clotting factor levels in relation to carrier status. We know that most carriers, here's a graphic showing the levels of factor level in carriers of hemophilia. Most of them will be here in the normal range from 40% to 80%, but there will be a significant number that will be lower, and there's about 30% of carriers that will have levels of under 40%, and we heard at the beginning somebody who could be very symptomatic from mild hemophilia. There are numerous platelet function disorders that go beyond the scope of the introduction, but suffice it to say of what we learned in regards to platelet disorders is the following. They are rare diseases, but when you take a cohort of women that have heavy menstrual periods and you test them for bleeding disorders, in the old studies published in The Lancet in 1998, we get the impression that platelet dysfunction is very low on the list of bleeding disorder diagnoses. Of the 17%, only one, didn't even deserve a percentage, had a diagnosis of a bleeding disorder. And we now know with the current literature and a review of the literature that platelet dysfunction might be the #2 diagnosis in women presenting with menorrhagia, and it ranges up to 50% of women. Now, I thought a zebra was rare, and this photo was talking about a rare zebra. And it's true that rare factor deficiencies are rare. We see them more because of referral bias into hemophilia treatment centers. Of the rare factor deficiencies, I would say that the factor 7 is probably the most common. But what's most particular and relevant to this group is that factor 7 deficient women have heavy menstrual periods and have a particular propensity to bleed from the uterine cavity. And in our personal experience, and for unknown reasons at this time, tend to have post-operative bleeding complications, probably more than some of the other factor deficiencies. The other thing about factor 7 deficiency is that it's probably one of the only ones that we have a direct therapy, replacement therapy. We have plasma-derived, but we also have recombinant 7A. And as you can see on many of the others, some of them don't even have plasma-derived virally inactivated products for treatment. So I'm going to end just with mentioning when women are affected with these bleeding disorders. And as you can see in the picture, certainly at the time of menarche, at the peripartum, and at the menopause. So all through the lifespan, basically. And what I'm showing here is that you have on the left here rare coagulation defects, von Willebrand, and carriers of hemophilia. And if you look, all of these disorders have menorrhagia. But where they might differ is bleeding during pregnancy. You may see here that women with rare coagulation defects are more apt to bleed antepartum than women with von Willebrand disease. And that's probably true of our clinical experience. In terms of postpartum hemorrhage, they're probably all the same, with the exception that von Willebrand will have a higher rate of secondary postpartum hemorrhage compared to the others. What people are a little bit less aware of, the menorrhagia and menorrhagia and postpartum hemorrhage are very common, but in terms of hemorrhagic ovarian cysts, many people don't know that there is an association with bleeding disorders. And the Israelis published in a retrospective review 6 women with bleeding disorders that were diagnosed on 11 episodes of hemorrhagic ovarian cysts, and now have opened an entire website and surveillance for this type of problem to try to establish the commonality with women and bleeding disorders. And in a study, a retrospective study by our colleagues in the USA with Andrew James, she reported in a case control that women with bleeding disorders, particularly von Willebrand disease, had higher incidence of ovarian cysts. So this also goes with the same. So I'm going to finish by saying what we do know. We know that inherited bleeding disorders are common, that women with inherited bleeding disorders may bleed, but they don't always. That genetic mutations do cause bleeding disorders, that bleeding manifestations may vary, and that accurate diagnosis is very important for optimal treatment. But what we don't know is the true symptomatic prevalence of all the bleeding disorders in women, why some women who bleed don't have a bleeding disorder, why some women with a bleeding disorder don't bleed, why individuals with different bleeding disorders bleed differently, and how treatments in women with bleeding disorders differ from women without bleeding disorders. And with that, I'll leave you with the concept that yes, times are changing, and therefore so are we. And so that's what we'll do today, starting now. We're going to change history together.